مراجعة على كل التيومر malignancy أو GYN malignancy اللي درسناهم خلال الأسبوعين الماضيين. راح أرجع أحاول أكمل الإندومتريال كانسر ونعمل بعدين questions and answers وبعدين cervical cancer و ovarian cancer. فراح أعمله باعتبار عنا 3 ساعات، إنه بأول 10 دقايق أو ربع ساعة ممكن نعمل مراجعة سريعة عن different topics وبعدين نفوت بالأسئلة. فبلشنا نحكي هذيك المرة عن الاندومتريال كانسر. الميجر ريسك فاكتورز اللي بتؤدي لحدوث سرطانات جسم الرحم عند النساء هو التعرض المزمن للاستروجين، إذا كان عن طريق الأدوية اللي بتاخذها النساء بعد سن اليأس، أو for other reasons مثل السمنة، عدم الولادة، polycystic ovarian syndrome. هذا كله بيؤدي لزيادة نسبة الأستروجين بالجسم وبيزيد نسبة حدوث سرطانات جسم الرحم. في طبعا كمان genetic condition Lynch syndrome that you are very aware of. Lynch syndrome بتؤدي لازدياد حدوث سرطانات الرحم، وكمان other cancer الموست famous هو الكولون كانسر والكاودن syndrome. هلا بالنسبة للبراكا 1 اللي درسنا بشكل كبير بالأوفيريان كانسر، كمان ممكن البراكا 1 ممكن يزيد نسبة حدوث سرطانات جسم الرحم، لكن البراكا 2 mutation does not seem to increase يعني risk of endometrial cancer. It increases risk of ovarian and breast but not the endometrial cancer. كمان مراجعة سريعة لللينش syndrome هي inherited dominant disorder. Patients that have a mutation بجين MLH1, MSH2, MSH6 and PMS2. هدول الجين are responsible for the repair of the DNA strand during cell division. فأي mutation بهالجين هذه تؤدي إلى تراكم يعني أخطاء DNA repair وبالتالي بتؤدي لحدوث سرطانات. وعادة هيدا ممكن تكتشف عن طريق الimmunohistochemistry by doing certain staining for mismatch repair proteins. The typical cancer اللي بتزداد عند المرضى اللي عندهم لينش syndrome هن الكولون، يوترس، بس كمان other cancer like stomach, small intestine, liver, gallbladder, ducts, urinary tract, and brain and skin can also be increased in those patients. All right. طيب هلا نجي whenever يعني هذا it's a theme that you're going to see across يعني all different solid tumors. And once you have a diagnosis of a cancer in a specific organs, next question لازم يكون what type of histology we're dealing with. For endometrial cancer there are different histologies. Knowing histology هي كثير مهم لأنه المعالجة ممكن تختلف من histology to histology. They are all called سرطانات جسم الرحم, but different histology require different treatment. So the most common ones are the endometrial adenocarcinoma. تقريبا أكثر من 80% من حالات سرطانات العنق الرحم هي this type of histology. بعدين في عندك clear cell carcinoma, papillary serous carcinoma, and then there is carcinosarcoma, which is also called Mullerian tumor, and then of course the sarcomas. وهلا يعني راح نشوف انه depends on what histology we're dealing with, what grade, especially in the endometrial cancer adenocarcinoma, treatment can be very different. So again راح ركز اكثر شيء هلا على الادenocarcinoma باعتبار it's the most common one that you're going to be seeing. And then we'll go talk about the other ones. بالنسبة للstage, stages, you have to kind of know what stage you're dealing with. So طبعا stage 1 لما it's confined to the uterus, بعدين بيقسموا stage 1A, 1B depending on the depth of invasion of the myometrium. بعدين stage 2 بيكون وصل للcervix. Stage 3 it's locally advanced, بيتقسم كمان ل A, B, C. A لما بيكون التيومر وصل للسيروسا, سطح جسم الرحم. Stage B there's invasion of the vagina or the surrounding tissues, the parametrial tissues. And 3C لما بيكون وصل للعقد الليمفية, whether it's pelvic or para-aortic lymph node. Stage 4, of course, it's either locally advanced, where it's invading into the bladder and the bowels, or distant metastasis, which is called stage 4B. Generally, like again, يعني نفس القصة هون إنه أي patient diagnosed with endometrial cancer, after you do the staging workup and you determine إنه the tumor is confined to the uterus, the patient should have surgery مع lymph node assessment. هلا هذه من أحد القصص اللي بتركز عليها كثير إنه most of the time when surgeries are done by gynecologists, they don't go on to have a complete lymph node dissection or assessment, and that is important in the staging and the decision on further treatments. فgenerally لازم يكون في assessment للpelvic lymph nodes, and then as far as the para-aortic lymph nodes, some centers are doing sentinel lymph node biopsy.
Doctor, should be any number of lymph node that surgeon have to excision?
I don't think we have such a exact numbers like مثل colon cancer. فيعني as long as they are staging them as like pelvic, right pelvic, left pelvic, para-aortic, but I don't think that they have specific numbers of lymph nodes that I know of. Good question. طيب هلا again, once we are determined after the surgery, the next questions you're going to ask to determine إذا هذا المريضة بحاجة لأدجuvant therapy are the following things that you have to assess. The histology type, adenocarcinoma لحالها versus all the other types. بعدين, if it is adenocarcinoma, are we dealing what grade of the tumor? 1, 2, 3. بعدين, the depth of myometrial invasion, that of course goes into the staging, and then the age and lymphovascular invasion. So just for the purposes of simplification, they classify the endometrial cancer as either local regional disease or disseminated disease. If it is local regional, they further classify it into low risk, intermediate risk, and high risk. Low risk اللي هن المرضى عندهم endometrioid adenocarcinoma and a good grade or a grade 1 or 2 on stage 1A. Those patients typically they don't require any further adjuvant treatment. If you're going into stage 1 and 2, then that is a intermediate risk, and there is a requirement for adjuvant treatment for these patients. And then the high risk can be any patients other than endometrioid, like the clear cell, the serous cell carcinoma, the carcinosarcoma, are all considered high risk regardless of their stage. They are classified under high risk. And that is, again, important to remember that stages 3 and 4A are, if you are dealing with endometrioid adenocarcinoma, stage 3 and 4A, that's considered high risk. So مراجعة سريعة again هون التركيز على endometrioid adenocarcinoma of the uterus. Stage 1A, grade 1 or 2, no further treatment is offered. If you are dealing with higher grade, then you may consider vaginal brachytherapy. Same thing in stage 1B. And then if you are getting into a higher grade, grade 3, stage 1B, then you are considering, most people, I mean, they give external beam radiation therapy, plus brachytherapy, systemic therapy, maybe not. And then when you are reaching to again, a grade 2, stage 2, grade 3, again, external beam and vaginal brachytherapy plus minus systemic therapy. Once you get to stage 3A and 4A, definitely those patients will need systemic chemotherapy. I mean, that's what we do here most of the time, plus minus external beam radiation therapy and brachytherapy. And stage 4B, there are certain cases that you could possibly still treat them with external beam radiation therapy, but معظم هدول patients, they require systemic chemotherapy. So هذا الحكي كله كان عن الاندومتريويد adenocarcinoma. هلا once we are into a higher type of grades, papillary serous, clear cell, and differentiated or carcinosarcoma, those are all considered high risk group, and those يعني across the board they will require systemic chemotherapy plus minus external beam and vaginal brachytherapy. So we're shifting into the low-grade sarcomas of the endometrial. If it is a stage 1, usually surgery and no further treatment is required. However, if it's stage 2, 3, and 4, then you may offer estrogen blockade after the surgery, obviously, and may also consider external beam radiation therapy. I tend to use aromatase inhibitors as adjuvant treatments. There are other options, but just because it's easy and familiar with the use of it in breast cancer, so I would be sometimes offering those patients aromatase inhibitors. Sarcomas, here, like if you look at the NCCN guidelines, they say could consider surgery or, observation or systemic chemotherapy adjuvantly. Depending, I kind of, discuss that with the patients, depending on her age, her comorbidities, and what have you. We will have to have a discussion about whether to offer the systemic chemotherapy. It's a truly stage 1 sarcomas. Higher stages, you're going to be offering chemotherapy plus external beam radiation therapy. And the regimen that I would typically use in those sarcomas are Gemzar and doxorubicin or doxorubicin-based regimen. Again, هيدا نفس تكرار إنه high grade histologies of endometrial cancer, you should offer them adjuvant systemic therapy regardless of the stage, plus the local therapy with external beam radiation therapy and brachytherapy. Let's see. Now we'll move into the stage 4. Stage 4 cancer of the uterus. The histology is going to help you in deciding, do you need to offer this patient systemic chemotherapy, or is it possible to get away with like a hormonal therapy? I have a patient actually that I had who had endometrial cancer many years ago. She recurred, I don't know, 3-4 years ago in the colon. She had surgery, and then I put her on Aromedix, and she's been on it now for many years and really doing very well. She never required any systemic treatment. However, that is a patient who has a very limited disease, obviously, with not a big load. However, if the patient has a widespread metastatic disease and they have issues with metastasis to liver, lungs, and causing a lot of symptoms, those patients, you should be offering them systemic chemotherapy. That's in the endometrioid adenocarcinoma. So you have the options of either endocrine or systemic chemotherapy. High risk histology across the board, you would be offering systemic chemotherapy. هلا مثل ما قلنا بالبداية إنه أحد الريسك factor for patient to have uterus cancer is Lynch syndrome, and those patients, if they have, like you're going to be offering the MMR status or checking on the MMR status. If they are positive or MMR deficient or MSI high, you can offer them single agent Keytruda. Another patient that I am treating currently, same thing. She had endometrial cancer many years ago, had only required surgery. It was a stage 1A, but she recurred in retroperitoneal lymph nodes, and she's been now on pembrolizumab for 2 years, and she's in complete remission. That's that. And then one group of patients that you should test the HER2 status is the patients with papillary serous tumor, because those patients could have HER2 positivity, and you should consider adding Herceptin to the chemotherapy. Okay. Now, again, if the patient is quite symptomatic, you should start chemotherapy, and then depending on response, decide if you want to switch to something else later. As far as the pembrolizumab is approved if the patient has MSI high or deficient in mismatch repair protein. Then you can offer the pembrolizumab by itself. However, if they are stable and they don't show any features of deficient mismatch repair protein, then those patients still can be offered immunotherapy, but with lenvatinib. So that's that's the other option that you may have, and those are second line usually. I don't. We'll just like very quickly touch on gestational trophoblastic disease. I probably in my career have treated maybe 2 or 3 of those patients. So it's a rare group of disease in which abnormal trophoblast cells grow inside the uterus after conception. It could be benign or it could be malignant. If it is malignant, it will be called gestational trophoblastic neoplasia. And then there are 7 risk factors that you have to calculate to figure out what to do for those patients who have gestational trophoblastic neoplasia. These risk factors are age, whether she had pregnancy before or not, the time between the pregnancy and the development of gestational trophoblastic disease, the HCG, the size of the tumor, site of metastases, number of metastases, and whether they had received any treatment before. And this is the schedule where you assign the different scores depending on whether these patients has these different factors. So the best group are the younger. The patient had a molar pregnancy before. And this happened within short period of time. The HCG was not that high at presentation. The size of the tumor is smaller, and even if they have metastatic lung disease, that's still considered they would give them a 0 score. While the highest group are obviously, the patients who presented way after their pregnancies with increased HCG, or those patients, a lot of time they present with vaginal bleeding, and they would think it's related to their menstrual period. But then when you do further testing, you find that they may have that. So some, more than 12 months, very high HCG. This disease can metastasize to the lungs, but also to other organs, spleen, kidney, liver, and brain. And then, of course, number of metastases high, number of metastases, and whether they received any previous treatment. So depending on what score you assign them, you would be recommending chemotherapy for those patients. So if the patient has a low risk, if she's in the low risk group, then it's possible to treat them with methotrexate or actinomycin D. I just finished treating a 23-year-old woman who came into the hospital. She was pregnant, came to the hospital, was bleeding. We found that she had molar pregnancy, and then on further testing, she was found to have GTN and was found to have metastasis to the lung. She received treatment, and it was very interesting pattern. She had multiple very small nodules in both lungs. So she received the single agent methotrexate, and she is now in complete remission. We followed the HCG as a way of deciding how she's responding to the treatment. For patients who are more advanced and a higher risk group, then this is the regimen that you would use: combination of etoposide, methotrexate, actinomycin, cyclophosphamide, and fulvestrant. All right, so that is for this part, and I'm going to switch now questions and answers. واللي رح نعمله إنه ما بعرف إذا رح نقدر يعني address all the questions. We'll ask or address as many as possible. بس إذا فينا نبلش مثلا كل واحد بياخد سؤال. We'll keep يعني going مثلا 1, 2, 3, and then we'll keep going with the questions. So without me calling يعني ما إنه لكم أو أطلب منكم إذا فيكم أنتوا يعني تتبرعوا لحالكم. So So let me switch to the questions part.
عفوا دكتور، السؤال بس بعد إذنك، إذا الكوريوكارسينوما كانت بالرحم هي نفس العلاج الجي تي إن؟
بالضبط. yeah.
تمام، بس الفيجو نشوف.
ها
أنا عندي مريضة من 3 شهور تقريبا اجتني بكوريوكارسينوما بالرحم، طبقت لها الفيجو طلع أكثر من 6، فأعطيتها إيماكو، أعطيتها تقريبا صار 3 جرعات. البت اتش سي جي كان فوق ال 50,000، نزل لل5، رد بعد اسبوع، وقفت له علاج اسبوعين عفوا، رجع طلع لل 25. رجعت اعطيتها مره ثانيه بصراحه اخر جرعه، ورجعت حللت لها اخر مره طلع 7. فبهالحاله هي شو المقبول وشو اللازم اعمل؟
So يعني it's nice إنه هي she continue to respond to the يعني treatment that you offered. If in case she is going to progress again, then you may have to change the type of chemotherapy. There is other يعني combination that I can يعني send it to you if you have problems with her in the future. So she needs to be continue to be monitored with repeat HCG on a monthly basis, or of course scan as well.
طيب
دكتورة الصوت كثير واطي.
صوتي واطي؟
ايوه دكتورة والله.
دكتورة
تفضل. عليت الصوت.
دكتورة دي ممكن من اعدادات الزوم يعني السيتنج تبع الزوم في يعني فوليوم ادجستمنت، وممكن تزودي الفوليوم تبع الميكروفون اذا بتحاولي.
طيب رح اشوف وين هيدا الاعدادات. اوكي هلا يعني احسن؟
ايه احسن دكتورة.
الله.
المونيتورنج للبت اتش سي جي مونثلي لمده قديش، سنه الا اكثر؟
Yeah, at least a year I would continue to monitor that patient.
والسيرجري الاكسجين للرحم اجباري هيك حاله دائما؟
نو اذا المريضه بعد عندها رغبه بانه تتابع يعني وبدها تحمل مره ثانيه of course we recommend for them not to get pregnant يعني خاصه in the first I would say again in a year to 2 years. You can avoid يعني you don't have to do, you can يعني do DNC to clean whatever you can clean and then you finish يعني or you clear the rest of the tumor by the chemotherapy. So yeah, بس إذا المريضة she has no interest in doing يعني getting pregnant again, yeah you can offer the hysterectomy.
يعني إذا كان الورم كثير معبي الرحم، أنا بكفي عن طريق الإيماكو يروح كلياته الورم بدون ما أعمل تجريف؟
لا لازم تعمل تجريف.
تمام، بعدين بيبقى بقايا بيروحوا بالكيموثيرابي. بعدين بقى لمدة شهرين لمدة سنة. مسموح الحمل بعد سنة إلا بعد أكثر من سنة؟
I think يعني هذا depends on the patients, but a minimum of a year to 2 years. 2 years is safer يعني عادة, just to see how يعني خاصة هلا إذا she just finished chemo, her body might not be ready يعني for pregnancy. So I advise at least 2 years.
تمام شكرا.
عفوا دكتورة بنفس الموضوع. هلا بظن انه مره قريت لازم نعطي 5 cycles ايماكو after normalization of beta HCG الكوريوكارسينوما.
Minimum of 4 to 6 cycles.
بعد ما يصير بتا HCG نورمال.
بالضبط.
تمام.
بعد ما يصير نورمال لازم نعطي 4 ل 6 سايكلز، الا حتى صار نورمال كلهم مع بعضه 4 ل 6؟
لا انت you treat following the beta HCG. Once the beta HCG has normalized completely, you continue to treatment for anywhere between 4 to 6 more cycles. So this particular patient, مثلا I treated, she had I think she received almost a year worth of يعني treatment until she became normal.
تمام، يعني بتم بعطيها ايماكو لحتى يصير البت اتش سي جي نورمال، بعدين بعطيها 4 ل 6 جرعات بعدين براقب.
بالضبط.
تمام.
اوكي سو خلينا نبلش بالاسئله. So anybody can start and then يعني the second person can pick up and so on and so forth. نبلش بس أنا رح أقلكم أي أسئلة لأنه ما بتهيألي رح نقدر يعني نعمل كل الأسئلة، فخلينا نبلش بسؤال واحد إذا ممكن. إذا حدا بيقرأ واللي يعني
أنا مو طالع شيء على الشاشة.
مو طالع شيء. Okay. Let me see. بين شيء؟
تمام طلع. واذا من تحت على اليمين فيك تكبري مشان تكبر الصفحه
من على اليمين. هلا هيدا it's a Microsoft Word.
تمام في تحت على اليمين بلس ماينس
بالزاوية.
okay. ايوه
اوكي
تمام.
اوكي هيك احسن. كمان
هو منيح اذا بيقدروا يقروا الشباب فممتاز. خلص ممتاز هيك شكرا.
طيب مين راح يبلش؟
طيب المشكلة طالع نصه ما
والله.
إذا بدك تحط التليفون، إذا بتابع على التليفون حطه بالعرض ملهم يمكن بيبين معك أحسن ولا لا؟
لا نفس الشيء بالسورس الصورة.
نفس الشيء.
ايوه هيك منيح. لا تمام هيك ممكن اقراه.
ايه تفضل لو سمحت.
62 years old has postmenopausal bleeding for the past 3 months. She presents to her gynecologist who perform a transvaginal ultrasound and exam that both reveals an endometrial mass. She ends up going for total hysterectomy with bilateral salpingo-oophorectomy and lymph node sampling that reveals stage 1, grade 1 endometrioid cancer. The lymph node assessment include evaluation of the nodal basins that drain to uterus, including a pelvic nodal dissection. No suspicious pelvic or para-aortic lymph node were seen. You review the pathology report that shows negative lymph nodes, 5% myometrial invasion, and no lymphovascular invasion. What is adjuvant therapy do you offer? ما في observation.
خليني ننزل لك اياها هي الأجوبة.
Observation. I think observation.
Absolutely. So why يعني أنت اخترت الobservation؟
لأنه stage 1 والانفيجن للميومتريا أقل من 1/2 وما في عنا ليمفوفاسكولار وما في عنا والجريد 1 وما في عنا ليمف نود انفيجن.
تمام عظيم.
بس بالنسبة للعمر دي عمرها ثانية 62. هلا أكثر من 60 ترانس أبدومينال بنعطيها إذا كان في عنا.
If she is more than 7, well, I mean, you know, you have to have يعني
بالنسبة للعمر البريكوثيرابي أكثر من 60 وأكثر من 70 كان ترانس بيلفيك راديشن.
That depends on if they have any risk factors. يعني هلا هيدي مثلا
تمام الانفيجن.
Right. So she has to have an older age and also like say lymphovascular invasion or deep myometrial invasion. Then you would offer brachytherapy if she has these risk factors. Next خلينا نجرب السؤال اللي بعده.
ممكن أنا؟
اي تفضل لو سمحت.
A 56-year-old female is إيش معناتها هي؟
So 56-year-old female status post total abdominal hysterectomy and bilateral salpingo-oophorectomy and lymph node.
And lymph node dissection and is found to have stage 4A endometrial carcinoma with endometrioid histology. The final pathology report reveals that the tumor is invading the bladder mucosa. She has no lymph nodes involved. What treatment would you offer next?
So
خيار الأول.
Yeah, بالضبط. So again, she fits into a high risk group. هذا يعني we're dealing with endometrioid histology, but because of the stage, she fits into the high risk group. Across the board, all the high risk group should be offered systemic chemotherapy. And then, of course, you can consider vaginal brachytherapy. For NCCN guidelines بتقول plus minus, if it is available and patients want to be, the vaginal brachytherapy usually improve the local control. It doesn't have any impact on the overall survival. So tumor-directed radiation therapy and brachytherapy is not an option here because it's of the stage. Chemoradiation with weekly cisplatin, usually this regimen is not used at all in endometrial cancer, but rather in cervical cancer. كان في عندها كمان anti-estrogen therapy. But yeah, for this particular patient, I would have chosen chemotherapy plus brachytherapy. All right, السؤال الثالث. ما في متطوعين؟
دكتور أنا
جميل، تفضل حسين.
تفضلك. 69-year-old present to go over treatment options for her metastatic uterine cancer. 5 years ago had total abdominal hysterectomy and bilateral salpingo-oophorectomy with lymph node sampling for stage 1A, grade 2 endometrioid cancer. She received no adjuvant therapy. A CT was done recently for slight dyspnea. She was having several lung lesions. One was biopsied showing endometrioid cancer. The tumor is MMR stable and no other actional mutation are seen in NGS testing. She is minimally symptomatic and is on receiving her quality of life. What therapy do you offer? Carboplatin and Taxol.
هيجي مريضة عندها stage 4 low-grade endometrioid cancer. She has, has very little load of tumor or tumor burden. So she does not express the MMR or microsatellite instability. بس المريضة عم يقول لك هون إنه she's interested in preserving her quality of life. So يعني chemotherapy typically would affect their quality of life. So what other options besides chemotherapy you could offer her?
Anti-estrogen therapy.
Anti-estrogen therapy, exactly. If she had, like tons of disease, she has a lot of metastasis to the lungs, she has mets to the liver, she is quite symptomatic for her disease, then I would definitely choose chemotherapy. For options of chemotherapy, BNC are possibility for advanced stage, endometrial cancer. However, so both in the old times, cisplatin, adriamycin, and Taxol was the regimen that was used, and they compared it to carbo and Taxol, and they found that they are very equivalent. And of course, the first regimen has much more complication. That is, typically for patients who require systemic chemo, we would offer them carboplatin and Taxol. Pembrolizumab is not an option because she is not showing any deficiency in the mismatch repair protein. So the correct answer هو anti-estrogen therapy.
دكتورة الانتي استروجين بتنعطى بالساركوما الادينوكارسينوما؟
You can give it in low-grade endometrial sarcomas. You can offer those patients حتى بالadjuvant setting, you can offer them anti-estrogen therapy. And of course, in the endometrioid cancer, a lot of these tumors, when you stain them for estrogen and progesterone, you see that they are staining positive, and that will give you a little more confirmation that they will respond to the anti-estrogen therapy. Okay, so I see we'll skip the question number 4. It's kind of هذا again, the two situations that you may offer anti-estrogen in a different ways are the endometrioid and low-grade sarcoma. All these other ones, papillary serous adenocarcinoma, clear cell, and carcinosarcoma, usually they don't respond to estrogen therapy. All right, so number 5, please.
مرام.
تفضل.
Which of those is considered as a risk factor for developing endometrial cancer? PRCA2 mutation.
بالضبط. Yeah, so all the other ones, Lynch syndrome, Cowden syndrome, granulosa cell tumor are known to produce estrogen. And that's why those patients have, if they have granulosa cell tumor, that usually associated with endometrial carcinoma, obesity, and polycystic ovarian syndrome. And let's see, we'll go to number 7 now. So if we can keep going reading so we can finish more questions. جور مين هلا؟
دوري دكتورة.
تفضل.
45 years old man undergoes PSO with lymph node dissection for recently diagnosed uterine endometrial carcinoma. The tumor invades into the stromal connective tissue of the cervix, but doesn't extend beyond the uterus. She has stage 2 disease, T2 disease. Pathology reveals that she has grade 2 features. She came to your office asking about adjuvant treatment. ممكن شوي دكتورة؟ تمام. She comes to your office asking about adjuvant treatment options. What do you recommend? Observation, chemotherapy with doxorubicin and paclitaxel, chemotherapy with doxorubicin and cisplatin, vaginal brachytherapy and or EBRT, chemotherapy with carboplatin paclitaxel.
So stage 2, grade 2, that fits into what's called intermediate risk group for recurrence. D, exactly. Yeah, so it's an endometrioid, it's a grade 2 and it's stage 2. So typically those patients do not require any systemic chemotherapy. Vaginal brachytherapy and external beam radiation therapy usually is enough to reduce chances of local recurrence. تمام. خلينا نروح للسؤال الثامن.
تمام. 62 years old female presents with bleeding from the vagina for the past 3 months. She is seen by her gynecologist and is found to have endometrial mass that was biopsy proven to be pure endometrioid uterine cancer. Cervical cytology is negative. CT chest abdomen pelvis with her oral and IV contrast reveals peritoneal disease, omental deposits, and some ascites. There is no evidence of liver metastasis or lung lesion. The patient has significant abdominal pain and undergoes a complete surgical debulking. What stage is this patient and what the therapy do you offer? The stage here 4A.
4A is when the invasion is into the local organs in the pelvis, like bladder and colon. So هيدي المريضة عندها metastasis. 4B بالضبط.
4B. في عندها تمام.
So she has mets to the omentum and the peritoneum.
تمام. معناتها الأوبشن هو D.
الأوبشن D. So يعني هون عم يقولوا لك إنه generally again she is will be offered palliative systemic chemotherapy. هلا external beam vaginal brachytherapy if the patient has quite a bit of symptoms related to her local disease. After administering chemotherapy, if they still have a big load of disease, it's reasonable to offer them external beam radiation therapy. So هون الجول طبعا منه cure. الجول للتريتمنت هو انه to help with the symptoms related to her disease. اوكي ننتقل على السؤال 9.
أيام.
تفضل.
58-year-old female present to discuss adjuvant treatment options for her recently diagnosed stage 1B, grade 3 endometrioid cancer. Pathology reveals positive lymph vascular invasion. She underwent TIH. كيف تنقرأ هي؟
Total abdominal hysterectomy and bilateral salpingo-oophorectomy.
كل مرة بنعيدهم كامل ما في مختصر؟
لا فيك تقول. She underwent surgery. خلاص all surgery.
All surgery. Yeah. And lymph node sampling. Fortunately, all lymph nodes sampled are negative for cancer.
Okay, so she is early stage 1B, but she is a grade 3, so she's poorly differentiated endometrioid cancer. So طبعا هذا you still offer surgeries, but what group does patients fit into? So there's low risk, intermediate risk, and high risk. She fits into the intermediate risk group because of the poorly differentiated findings. So what would you offer her?
Maybe C.
C. Yeah,
Or E.
I think that's reasonable. Of course, observation is out. You cannot really offer this patient observation. Chemotherapy by itself in a stage 1B is not yet indicated. So for these patients, external beam radiation therapy and vaginal brachytherapy plus minus systemic therapy is the right answer. تمام.
Thank you.
تفضل. 10. خلينا ايه تفضل 10 اذا ممكن نعمل رقم 10.
Uh, 61-year-old female presents to discuss adjuvant stage 2 endometrial cancer. The patient undergoes total surgery and surgical staging. The tumor invaded the stromal connective tissue of cervix, but it does not extend beyond the test. She was no lymph node that are no systemic evidence of disease. What therapy do you offer? Stage 2, clear
But what
cell.
type of histology?
Clear cell, high risk.
Clear cell carcinoma, high risk.
بس الدكتوره شوي لقدام لانه الاجابات الاخيره ما هي مبينه.
تمام. هيك.
تمام. دي chemotherapy and radiation.
Exactly. So again, just to emphasize, in a patient high risk histology, those you always have to offer them systemic chemotherapy, regardless sometimes of the stage, whether they are early stage or more advanced stage. Versus the endometrioid, you have to have more information to decide on how to treat them adjuvantly. تمام، معناتها شكلكم مركزين. طيب. Number 11, please.
Okay. 58-year-old female has recently been diagnosed with stage 4 endometrial cancer. She had a 4-month history of progressively worsening dyspnea. Chest imaging reveals bilateral pleural diffusion. Right chest diagnostic therapeutic thoracentesis is performed and reveals an endometrial cancer. يعني stage 4B. You review the pathology and it's a papillary serous tumor, high risk يعني. The tumor is micro satellite stable يعني MMR stable and HER2 negative أيضا for performance status 0 and she has no comorbidities which the following نختار ممكن B.
B is a reasonable option. A is also a reasonable option. And adriamycin cisplatin is more, probably would consider that in other type of histology. So I would say A or B, but in reality, most of the time we use A because carboplatin and Taxol tend to be less toxic compared to the cisplatin.
Performance status 0.
Yeah, still يعني لانه equivalent هن two regimens. هو يعني مثل ما ذكرت من قبل الcisplatin, adria and Taxol were the preferred regimen for a long time. بعدين صار clinical studies compared هال two regimen Taxol carbo and paclitaxel, adriamycin, and cisplatin, and they found no difference in efficacy, and of course less toxicity with Taxol and carbo. So بالpractice we almost always we use carboplatin and Taxol.
هون ما ممكن نضيف ABRT؟
So it seems like her most symptoms are related to the systemic disease. يعني عندها progressive shortness of breath, عندها pleural effusion. So all that يعني kind of, you want to control the systemic disease and control her symptoms. I would only offer chemotherapy. Doesn't seem like she's having a lot of problem in her pelvis per se. So بالنسبة يعني high risk, papillary serous carcinoma is high risk. In the decision on a stage 4, it's between once you have someone with a stage 4 endometrial cancer, you want to decide if those patients require chemotherapy, immunotherapy, or anti-estrogen therapy. In stage 4, you could use anti-estrogen therapy in conditions
low
of
grade.
Stage low grade, not much, symptomatic, etc. Those you could definitely use anti-estrogen. But anybody who has a lot of symptoms, even if they are endometrial cancer or other, high-risk histology, you should always consider systemic chemotherapy and then immunotherapy as a second line if they have microsatellite instability. طيب خلينا ناخذ يمكن سؤال واحد وبعدين we'll move to the next
عفوا دكتورة، بس بالنسبة للسؤال المضى هلا بالان سي سي جايد لاينز اول شيء بيحطوا لنا كلينيكال تريلز بريفيرد بعدين بنحط
true يعني yeah if you want to be يعني شو بيقولوا politically correct, you always have to consider clinical trials if clinical trials are available, definitely. So, I think I'm going, let's see. ناخذ بس سؤال واحد كمان. Let me see, we'll choose one more. اوكي خلينا نقول السؤال رقم 14. طيب هيدا اخر سؤال بهالسكشن هيدا. تفضل.
62 years old female undergoes surgery. تمام انا
تفضل.
اسمع صوتي؟
اي
تمام. 62 years old female undergoes surgery and surgical staging for her recently diagnosed endometrial uterine adenocarcinoma. Final pathologic analysis reveals plus para-aortic lymph node involvement. She has stage 3C2 disease. CT imaging reveals no evidence of systemic disease. What is offered as adjuvant therapy? Radiation, الHRR analog, carboplatin, paclitaxel, زائد ناقص vaginal brachytherapy or EBRT, زائد ناقص vaginal brachytherapy, زائد ناقص systemic therapy. Observation, none of this.
So she's a stage 3C. Yeah, stage 3C endometrioid adenocarcinoma. And here we don't even care about the exact grade because it's already stage 3C. So the correct answer is C, chemotherapy plus minus, brachytherapy and or external beam radiation therapy. اوكي تمام. هلا بس مشان مراعاة الوقت راح اوقف بهدول question هون و move to the second topic if possible. So go into the cervical cancer. اوكي سو كمان هيك رح اعمل كمان مراجعه كثير سريعه للسيرفيكال كانسر وبعدين ننتقل للاسئله بهذا التوبيك. So I'm going to skip a lot of slides بس ركز على كم slides هون. Again, the most important risk factor for cervical cancer هو ال HPV. تقريبا more than 98% of cervical cancer are HPV related. By يعني the knowledge إنه في HPV virus as cause for cervical cancer, different vaccine has evolved over the last decade or two. أول واحد كان السيرفايركس اللي فيه 2 strains بيغطي 2 strains اللي هن most commonly cause cervical cancer. More than 70% of cervical cancer caused by 16 and 18 HPV. بعدين إجا الكارديسيل had more of coverage cover subtype 6 and 11 وآخر واحد طلع كارديسيل 9 اللي فيه 6, 11, 16, 18, 31, 33, 45, 52 and 58. Most common histology هو squamous cell more than 70% و adenocarcinoma is you know less common. All right. Staging system again depends on the depth of invasion, the extent of the disease. So stage 1 is usually confined to the cervix. بعدين بيتقسم ل 1A1 and 1A2. 1A1 is less than 3 millimeter in depth. Stage 1 generally is يعني it's not really visible by physical exam, but on biopsies, patient is diagnosed with you know cervical cancer. And on pathology, you would determine if it is less than 3 millimeter or more than 3 millimeter depth of invasion. Stage 1B, what cancer is visible and you can measure the size of it. So it بيتقسم كمان ل 1B1, 1B2, 1B3 depending on the size of the tumor. 1B1 أقل من 2 سنتيمتر, 1B2 بين 2 وال 4, 1B3 is more than 4 centimeter. Stage 2 هلا بلش to expand. The tumor is expanding into you know beyond the uterus. It's getting into the upper 2/3 of the vagina or to the but did not extend to the pelvic wall. كمان بيقسموا ل 2A1, 2A2 and 2B. 2A1 tumor is less than 4 centimeter, 2A2 is more than 4 centimeter, and 2B there is a involvement of the surrounding tissue, the perimetrium. Stage 3 هلا بلش الكانسر go into the pelvic wall or into the lymph node and divided into A, B, and then C, and then 4A locally advanced into the bladder or the colon, and 4B distant metastasis. So just يعني for simplification, if it is stage 1A1, like less than 3 millimeter invasion, then it's simple hysterectomy for women who are done with having babies. If they are still desire more pregnancies, then you can offer them comb biopsies. If we have a little more deeper invasion, like more than 3 millimeters in invasion, 1A2 or 1B1, then you have to offer them hysterectomy. There are times when you could offer tracheolectomy, which is يعني basically just resection of the cervix without taking out the whole uterus. And then if you're locally advanced disease, stage 1B2, 1B3 to stage 4A, the primary treatment is chemoradiation, and then distant metastasis, it's systemic treatment. After patient has hysterectomy or surgery for her early stage cervical cancer, the next question would be on, if this patient require any further adjuvant treatment. So I'm just going to go through those again. 1A1, simple hysterectomy or conization, 1A2, 1B1, radical hysterectomy, and lymph node dissection. After surgery, you're going to look at pathology reports and you're going to determine if this patient require any further adjuvant treatment. If the patient is classified as intermediate risk, similar to what we've seen in the endometrial cancer, and they use something called SIDLES criteria, then this patient will have to have radiation therapy. However, if she has high risk, then she will require after surgery, after hysterectomy, chemo and radiation therapy. So she has criteria for high risk disease, positive surgical margins, positive lymph nodes, or perimetrial involvement. SIDLES criteria, which put the patients into intermediate risk group, is a larger tumor, more than 4 centimeter, deep cervical stromal invasion, and positive lymphovascular invasion. Those patients in intermediate risk group, you should offer them adjuvant radiation therapy. Again, if the patients have surgical margins positive, lymph nodes positive, perimetrial involvement, then the adjuvant treatment should be a combination of chemo and radiation, while if she is intermediate risk group, a little larger tumor, if it's deeply invading into the stroma and or positive lymphovascular invasion, then adjuvant radiation therapy would be enough. All right, so okay, so that's just kind of, and the preferred combination of systemic chemotherapy would be weekly cisplatin. In the past, they used combination of cisplatin and 5-FU, but they found that 5-FU was not adding much to the patient's outcomes. So the standard of care now is weekly cisplatin with radiation therapy, which usually 5 to 6 weeks. That's for early stage. Patients has been examined by gynecologists. They decide that this patient has a small tumor that they could undergo surgery. Then the treatment is surgery, and then you decide after that whether you're going to be doing combination of chemo and radiation depending on the risk factor. However, there are a group of patients who classified as locally advanced, and those treatment for them is always chemo radiation therapy. And that locally advanced is, some of the stage, it's actually stage 1B3 and 2B, and then of course stage 3.
دكتور عفوا، يعني هلا نحن معناته اذا ستيج 1A2 or 1B1 اجباري لازم نعمل نحن هيستريكتومي، ما بصير نعمل تراكيلكتومي، ما هيك؟ بعدين بنشوف الريسك.
Yeah, for very يعني هلا 1A1 ممكن تعمل لها conization only, right? Like or tracheolectomy. But if it is, like if the patient يعني desire fertility preservation, but if it is more advanced, depending يعني you have to like offer hysterectomy, radical hysterectomy, if the patient is surgical candidate. Okay. So chemoradiation, again, here a study that was done, randomized 403 patients who had stage 2B to 4A, and some of the 1B and 2A were also involved or, included in the study. They were randomized to either radiation alone versus chemoradiation. And the group that received a combination of chemoradiation did much better than the group that did radiation by itself. Let's see, I guess it's just repeating. Okay, so again, you're going to be thinking of it, okay, this is early stage, I can do surgery, patient have surgery, and then you decide on adjuvant treatment. Or it could be locally advanced. Patient surgically, it's not a surgical candidate because the size of tumor is big, because you know, like other kind of risk factor that the patients may have. Then you are going to be offering chemo and radiation. And then of course you have then your stage 4. Stage 4 metastatic or recurrent cervical cancer. The standard of care is combination of Avastin, Taxol, and cisplatin, or carboplatin. You know, they are quite equivalent. Other possible agents include topotecan, Taxol, and Avastin. And then, of course, for patients who have contraindication to bevacizumab, you can use chemotherapy without the addition of bevacizumab. And so bevacizumab has proven to increase progression-free survival, but I don't think they had much better outcome in terms of overall survival. Taxol carbo is equivalent to Taxol and cisplatin. And if the patients progress, then you could consider a single agent, pembrolizumab, if they are PD-L1 positive, or they have microsatellite instability, similar to what we've seen in endometrial cancer. And so now we typically use those immunotherapy, and there are studies that are looking into adding immunotherapy to chemotherapy, but it's still the clinical trials. In practice, we use at the time of progression pembrolizumab as a second line. So again, summary: early stage disease, surgery, hysterectomy, tracheolectomy, or conization, locally advanced chemoradiation, recurrent disease. Oh, I didn't mention it. If they have only recurrence in the pelvis, it's possible to offer them, you know, surgery called pelvic exenteration, where they basically resect everything that is in the pelvis, including the bladder and the rectum area as well. I've never seen patients opting to do this, but it is an option. And then for metastatic disease, palliative chemotherapy. All right, so that is my recommended diet kind of summary. So I'm going to move into the questions now. All right, so do you see my screen?
تمام.
اوكي. طيب نفس الشيء هلا اذا كل واحد بيتطوع بياخذ سؤال ومنتابع يعني بالدور.
A 48-year-old female is started.
Yeah. يعني حتبلش.
Started to start concurrent chemoradiation for stage 3A cervical cancer. The carcinoma involves the lower third of the vagina with no extension to pelvic wall. No lymph node appear to be involved. Systemic imaging reveals no evidence of metastatic disease. Which of the following does not represent and standard treatment of are for her? not the standard, not to present a standard.
kind of a little يعني هيدا سؤال شوية
الدي مالونا
بالضبط. T and the E يعني in a way. again the standard هو cisplatin مع radiation therapy concurrently, and then at the end of يعني chemotherapy and radiation therapy, brachytherapy, all those patients with locally advanced cancer, cervical cancer will receive brachytherapy. Carboplatin is reasonable if the patient has issues with her kidney function. And then cisplatin and 5-FU, like we said, has been used in the past, but we don't tend to use it, but it's still a valid option for such a situation. All right.
A 32-year-old female who immigrated from Vietnam to the US present to her gynecologist for a routine exam and was found to have a suspicious lesion on her cervix. Further evaluation show she has a stage 1B1 cervical cancer. The total invasive tumor is less than 2 centimeters. She recently got married and strongly desires to have children. What do you tell her in regard to therapy?
So she has a resectable tumor, stage 1B1. It's a small tumor, and typically you would offer those patients hysterectomy. بس هيدي in particular بتقول لك لا أنا بدي أجيب أولاد. I just got married and I want to have children. So what other option you could offer her?
ما لازم يكون في كون ريسكشن قمعي استئصال قمعي.
هذا الكون resection for يعني very very early, like 1A1, that's who you would offer conization. That you cannot see it, but هذا it's visible on exam. She has a tumor that is visible, but it's small. It's 2 centimeters. So conization will not work for such يعني situation.
معناته observation B.
أو إيه؟
Observation, no, I mean, she has not had surgery into هلا. You just diagnosed her and she has cervical cancer. The tumor is still there. You just got a biopsy from it.
Trachelectomy?
Exactly, yeah. So the correct answer is trachelectomy. Trachelectomy means يعني the cervix will be resected only. Somehow these patients can still go, and have, pregnancy afterward. But I think it's a high-risk pregnancy. And also pelvic lymph node dissection. These two has to be done to exactly determine the stage that she has.
طب دكتورة إذا ما في عنق رحم كيف يصير في حمل؟ يعني يصير في تصنيع عنق رحم؟
Yeah, no, they still are able to go, and to be honest with you, هدول الحالات يعني أغلب ما بتجي يعني I never seen this very early.
يعملوا سيركوليج يمكن بعد يعملوا سيركوليج بعد التراكيلكتومي.
Possible, yeah, it's a good question. Okay, so we'll move to number 7, please.
52-year-old female was recently diagnosed with cervical squamous cell cancer. Staging evaluation reveals 1.5 centimeter cervical lesion with no invasion of the parametrium, no lymph nodes, and no distant metastasis. The tumor is staged as 1B1. more than 5 millimeter depth of stromal invasion lesion limited to the cervix uteri يعني هون intermediate risk. So the radiation therapy to the pelvic, see, surgical then radiation.
Yes. So let's see. She has early stage. It's a stage 1B. So surgery has definitely to be considered. It's still like confined to the cervix and small tumor. It's a 1.5 centimeter. So you're going to think, yeah, surgery is definitely what this patient needs. She's 52, so she's probably not interested in fertilities. So you're going to offer radical hysterectomy with pelvic lymph node dissection plus minus para-aortic lymph node dissection or sampling. The chemo radiation therapy will be offered if this patient, after her surgery, you find that she truly had lymph node positive or margins of the resection are positive or parametrium involvement, then you would offer her adjuvant chemo and radiation therapy. And after surgery, radiation therapy could be offered if she has any of the risk factors, which is lymphovascular invasion or a deep stromal invasion or large tumor. But we already know that she has a 1.5 centimeter. So unless you find lymphovascular invasion on surgery, otherwise you don't offer any adjuvant treatment for this patient. So the correct answer is A.
بس ليش مو كاتبين هون إنه في radiation؟
لا هيدي again this is a very early stage cervical cancer.
بس مو في intermediate risk؟
She does not have any, we don't know that she has any هذا ال upfront treatment. هلا اجت لعندك فحصتها عندها stage 1B1. The first option should be offered always surgery. Those patients who have a small tumor not very deeply invaded and it's not metastasized, then surgery, hysterectomy and lymph node dissection.
وهون إنه أكثر أو يساوي 5 ملم بالديب، مو هذا من الانترميديت ريسك؟
That is considered intermediate risk, yeah. But again, ما عم يسألوك what you're going to be offering afterward. They're asking first treatment option. So هون السؤال عن first things that you're going to do for these patients, not about the adjuvant treatment.
Okay.
Okay. And we'll move to 8, please.
The 52-year-old female in previous question undergo radical hysterectomy and pelvic lymph node dissection. Her final pathology is reflected and she is found to have positive margins. In taking to pathology, it was R1 or microscopic margin. What would you recommend as adjuvant therapy? cisplatin.
Cisplatin.
أنا بروح على الكيمو راديشن والله.
بالضبط. Exactly. So
كيمو راديشن حصرا لأنه lymph node والpositive margins والبارامترال بدها كيمو راديشن.
Right. Yeah. So she had surgery because on the clinical exam she was found to have early stage. So the surgeon is going to do their surgery based on clinical evaluation, physical exam, as well as staging system. So they decide that she's 1B. So she has the surgery. However, the tumor, they cannot resect the whole thing. It seems like they have left some tumor there. So you should offer this patient concurrent chemo and radiation therapy. The other possible risk factor that will make that decision on adjuvant chemo radiation after surgery is, again, the positive margin, positive lymph nodes, or parametrial involvement. All right, so we'll move to number 10.
تمام. 57 years old female was found to have a 7 centimeter mass in the cervix that extend to the right pelvic side wall, stage 3B disease. CT imaging corroborate the above findings and show no distal metastasis or pathologic appearing LAD. Biopsy of the cervical mass shows squamous cell cancer. What treatment do you offer?
So this is a locally advanced disease. It's a quite large tumor. It's extending to the pelvic side wall. Is this patient a surgical candidate?
Chemoradiation. Chemoradiation.
Chemoradiation, exactly. Let's see. Yeah, I think it's interesting. They have a number C where they are offering radiation therapy, and then after radiation, radical hysterectomy. That is not something we ever do, even if the tumor shrinks down right from the beginning. If you decided that in all patients, MENA candidate for surgery, then you would proceed directly with concurrent chemo and radiation therapy. So the correct answer is D. All right, number 11, please.
A 39-year-old female is found by her PCB to have a significant iron deficiency anemia. It's determined that is due to excessive menstrual bleeding. She has completed all childbearing. She elects to undergo a simple hysterectomy for uterine fibroids that were causing her marked bleeding. She was incidentally found to have stage 1A1 cervical cancer with lymphovascular invasion. Margins were negative, and PET scan reveals no evidence of distant disease. What do you offer at this time?
So she had simple hysterectomy on the fibroid tumors, but then بعد surgery was done. They had no idea that she had cervical cancer, but then بعد the surgery, they found that she actually has stage 1A1 cervical cancer في lymphovascular invasion. That is like the part that you have to focus on.
Maybe observation?
No, she has lymphovascular invasion. You have to do something a little more than observation. You could, discuss that this patient, we really did not do a complete surgical assessment. So he بس عملوا له simple hysterectomy. They didn't do the lymph node dissection. So you could consider having, this patient to have complete her surgical staging with a radical hysterectomy and pelvic lymph node dissection. And then they say like number 1A is also could be correct, but because these patients anyway, you're going to be offering them a radiation therapy. But in my opinion, if she somehow has also lymph node metastasis, you're going to be adding chemo and radiation to her adjuvant treatment. So I would say the correct answer is C. So you complete surgical staging with modified radical hysterectomy, pelvic lymph node dissection. All right. Number 12, please.
A 64-year-old female with history of cervical cancer present to see you for dyspnea. She has no significant PMH except for her cervical cancer. 4 years primary medical history. Ago, she underwent chemoradiation with cisplatin for stage 4A cervical cancer. You order a CT scan of the chest, abdominal, and pelvic. That unfortunately reveals metastatic disease through the abdomen. Para-aortic lymph node is biopsied revealing cervical cancer. No clinical trials are open. The tumor is profiled and the PD-L1 is absent. Which of the following therapies offer the best overall survival rate? Maybe E, cisplatin, paclitaxel, bevacizumab.
Yeah, that is the answer. Obviously, these, carboplatin and Taxol could be, and I don't know if I agree with the overall survival rate. I would say progression-free survival is what's improved in those patients, but I guess that's the closest, Yani, answer. Cisplatin, Taxol, and bevacizumab is better than chemotherapy alone. No rule for FOLFOX, obviously, because she has metastatic cervical cancer. They told us she has dyspnea, but ما قالوا لنا what's going on in her lungs. Just said that she had advanced stage in her abdomen. So notice, the recurrence was like 4 years later, which and she had the stage 4A. It's kind of impressive that she lasted that long. Most of those patients recur in shorter period of time. Okay, so راح ننتقل number 14.
42-year-old female present to see you for recently diagnosed invasive squamous cell carcinoma of the cervix. She has a 1 millimeter invasive tumor with no lymphovascular invasion. She is done with childbearing, but adamant.
Adamant, يعني she doesn't want to have, like complete surgery.
About not receiving surgery. She's staged as having 1A1 disease. What therapy do you offer for her? I think B. I don't know.
So
maybe C, colonization
yeah,
of the cervix. Yes.
Exactly. Yeah. So Haiti, again, remember here she has 1A1 is the only kind of with no other risk factors associated with the 1A1. Those patients can have conservative surgical approaches. So conization, since she is not interested in having, hysterectomy, is a reasonable option. No need for lymph node dissection in those patients because she does not appear. She has, very superficial tumor and there is no evidence of lymphovascular invasion compared to the other patients who had hysterectomy because she was bleeding and she was found to have lymphovascular invasion. Those patients, they should, have further surgery considering that lymphovascular invasion there. Okay. We'll move to number 19. Number 19, please.
A 66-year-old female is a concurrent chemoradiation with cisplatin and
66
pelvic biopsy.
year old female is concurrent.
كمل دكتور حسين مشكلة.
سمير هياخد سؤال.
Uh, 66-year-old female, concurrent chemoradiation and prolific radiation radiotherapy for stage 3A cervical cancer that was diagnosed 1 year ago. Repeat CT 3 months after completing therapy. Reveal complete response. Unfortunately, 2 years after the patient complete chemoradiation, she cervix relapse in the vagina with cervical SSA, measure 4 centimeter in size. Radiation oncology is consulted and no further radiation can be overhead. Repeat PET-CT. Reveal no evidence of distant disease. She has BS0 and wants to force therapy that over here the best chance for a cure. What therapy do you offer? D.
D. So why did you choose D? So she has local recurrence just in the pelvis, no evidence of distant metastatic disease. The only treatment that maybe, give her a possibility of cure is pelvic exenteration, where they remove everything in the pelvis. If she refused, or patients is not a candidate for pelvic exenteration, those patients I would typically treat with systemic chemotherapy. She has received radiation therapy. Right. So D is the answer. That's correct. Okay, we'll move to 21.
Uh, 56 years old female is recently diagnosed with cervical squamous cell cancer. Her clinical stage is felt to be stage 1A1 with no lymphovascular invasion. HPV is detected in her pathologic specimen. She undergoes a cone biopsy and has negative margins. She then undergoes an extrafacial hysterectomy. Restaging study 6 months later reveals right sides pelvic LAD that is biopsy proven to be cervical cancer. Surgical resection is felt to be too morbid. She has no distant metastasis. What do you recommend it? Maybe C.
So she has, she had a stage 1A, and they didn't see any lymphovascular invasion. They did the hysterectomy. Of course, no lymph node dissection was done, which is considered within the standard of care, but yet those patients can recur. And she has recurrence only in the lymph nodes. So I would think of this as locally advanced cervical cancer, not, like a stage 4. So this is, fits into a stage 3C now. So she was stage 1A and then was the recurrence. she is more like a locally advanced stage 3C. So I would probably recommend
Oh,
for
D.
her D, exactly. Yeah. So systemic therapy only if she has, you know, distant metastatic disease. But since she has recurrence only in the pelvis lymph node, it's reasonable to consider cisplatin and radiation therapy only. All right. So we'll move to the next. 22.
عفوا دكتورة، بس في عندي سؤال بعد إذنك.
تفضل.
لو بدي اختار انا خيار اذا كان في عندي ريكورنس بالمنطقه بالحوض، وكنت عاطي انا كيمو ثيرابي، فنحن اخترنا مثلا بلفيك اكستنريشن. طب شو بهالحاله هي الجراح بيشيل؟ شو اللي بيشيله بالحوض؟
They remove, because remember هدول patients هدول locally advanced, they still have their uterus, they still have, you know, like all the organs inside the pelvis. So بيعملوا hysterectomy وبيعملوا يعني clearance of all the يعني content of the pelvis. بياخدوا بيشيلوا البلادر، بيشيلوا part of the rectum. So it's very يعني very extensive surgery.
طب هاي العمليه فينا نستخدمها اذا كان في عندي نفس الشيء بالاندومتريال كارسينوما؟
You mean
نفس الشيء صار عندي.
If the patient has يعني had received chemo and radiation before.
Yes, and recurrence only in the pelvic.
Yeah. هلا majority of patients يعني with what's considered to be a you know uterus or confined يعني to the uterus, they undergo hysterectomy anyway. So يعني most of these patients when they recur in like other organs. I've never seen anybody doing pelvic exenteration in endometrial cancer. Most of the time when they recur, they have somehow distant recurrence. So yeah, I don't think that is something that I've ever seen, you know, recurrence of endometrial cancer happening just in the pelvis.
طيب, okay, thank you.
Number 22, please.
Uh, 59-year-old female develops postmenopausal bleeding and was found to have a suspicious mass on transvaginal ultrasound. Biopsy was performed and reveals a serous carcinoma. She undergoes a transabdominal hysterectomy with bilateral salpingo-oophorectomy, surgical staging, and is found to have stage 2 uterine serous carcinoma. She undergoes adjuvant chemotherapy with 6 cycles of carboplatin and paclitaxel. She also received the external beam radiotherapy and vaginal brachytherapy. 4 years later, she presents with shortness of breast, and imaging reveals 10 bilateral lung lesions. A biopsy of a lung mass confirmed uterine serous carcinoma. Her performance status remains quite robust. The patient is MMR proficient. The recommendation by the medical oncologist is to start palliative chemotherapy with carboplatin and paclitaxel. Which of the following predictive markers could one consider sending for on the tumor to confirm on another therapy offers this patient with serous uterine cancer? HER2, C.
Exactly. I don't know ليش هون يعني حاطين سؤال تبع endometrial cancer in the midst of cervical cancer, but anyway, yes, I think the correct answer would be HER2 there is a chance that this patient may be HER2 positive, and you would throw in there Herceptin as well. BRAF and RAS, هدول mTOR الحقيقة they are seen in other histology of endometrial cancer that those patients may have such findings. فإن serous carcinoma of the uterus, HER2 should be tested. Okay, so 23.
A 62-year-old female is found to have a suspicious lesion on her cervix during a routine gynecology exam. Of note, the patient is HPV positive but has not seen any physician for over 10 years. The examination reveals a cervical cancer invading beyond the uterus, but not to the pelvic wall or to lower third of the vagina. The clinically visible lesion is 3 cm in size. The patient is felt to have 2A1 disease. CT imaging reveals no suspicious lab. She is referred oncology. What is the best treatment for hair?
So she has a 3 centimeter tumor. It's extending into the upper 2/3 of the vagina. No other findings of lymph node metastases. So look like it's still organ confined cervical cancer.
Maybe see.
So so again هيدي طبعا يعني has to happen in concurrent with discussion with the surgeon. With the stage 2A, a lot of time those surgeons, they feel like they could resect these tumor with negative surgical margins because it's still like confined into the uterus and the upper 2/3 of the vagina. So for stage 2A1, you could offer still hysterectomy and pelvic lymph node dissection, and then subsequent adjuvant therapy based on what you find on pathology.
يعني دكتورة الهستريكتومي كمان ال 21A بدخل فيها؟
Yeah. You know, for again, if it's, I think anything less than 4 centimeter, and they are able to, you know, on physical exam and surgical or imaging studies, if they feel like those patients are surgically can be resected, then they would proceed with the surgery. That would give them the best options in terms of survival.
هلا هون عندنا حتى احيانا الجراحين بيقولوا ستيج 2 بي ممكن يعملوه مع تنظيف العقد الليمفاويه، فنحن بنوافق على هالشيء هذا بعد ما نحوله على الكيمو راديشن.
Yeah,
no, only
if lymph nodes are involved, خلاص هذا يعني had considered locally advanced, you should not proceed with surgery. The standard of care here is to give concurrent chemo and radiation therapy.
بس 2A كمان locally advanced.
2A, but it's not يعني it's just in the upper 1/3 or 2/3, 1/3 of the vagina. Yeah. So yeah.
1 or 2/3 of vagina.
Mm-hmm. So
okay.
Somehow they can think that these are surgically resectable. All right, so we'll move to 25. Please. I think this is another
72-year-old female who is in good health develops, acute incident of uterine bleeding, she is promptly evaluated by the gynecology team and is found to have a mass in transvaginal that is biopsy proven to be an undifferentiated uterine carcinoma. فهون high risk. She undergoes to a total hysterectomy, أيضا bilateral hysterectomy with surgical staging. She's found to have stage 2 tumor. She have no lymph node involvement seen on pathologic analysis. CT imaging has been performed and shows no evidence of metastatic disease. So, what do you recommend as adjuvant therapy? معناته هون uterine cancer وهاي ريسك عنا ف stage 2 ممكن نحن نختار C.
So again, the histology is what's going to make your or direct you into the decision يعني, of how to treat this patient. So she is a stage 2, but she is a high risk with high risk histology, which is the undifferentiated uterine cancer. So how would you approach her?
Yes. معناته ممكن D.
Yeah. Yeah, see هون يعني kind of showing how a lot of those patients with diagnosed endometrial cancer, they end up having surgery for their cancer because obviously they can resect it considering that it is in the body of the uterus. And then subsequently the adjuvant treatment should be offered, depending on the risk group. Regardless يعني حتى لو كانت stage 1 undifferentiated carcinoma, you would offer adjuvant treatment for this patient. All right, number 26, please.
A 59-year-old female is undergoing palliative therapy for stage 4 uterine serous cancer. She was diagnosed 6 months ago when she developed post-menopause bleeding, staging study at that time, unfortunately showed the liver and lung metastasis. The later was biopsied to confirm the diagnosis. Her tumor was tested for HER2, and she wasn't HER2 positive. She was started on chemotherapy with carboplatin and Taxol. Unfortunately, despite the initial response, she developed progression of her disease after 6 cycles of therapy. She continued to have repost bilirubin status, and she has no other condition. Her family history is same for ovarian and colon cancer on paternal side. What do you recommend?
So the family history of ovarian and colon cancer, what makes you think of?
بدنا نتحرى متلازمة لينش MMR testing.
Exactly, yeah. So that is one of the clue, this patient may have Lynch syndrome. But even in the absence of such a family history, I would have also recommend that this patient have MMR testing, because if she turned out to be positive with a stage 4 uterine cancer, I would offer single agent pembrolizumab. However, if she's stable, you could also have the option of offering combination of pembrolizumab with lenvatinib. All right, so let's see. Number 27, please.
Uh, 68 years old female, present to start second-line therapy for her stage 4 cervical cancer. She immigrated from China 5 years ago and has never sought medical care. Due to worsening low back pain, she presented to a local ED. Imaging at that time revealed widely metastatic disease with bone lesion. Biopsy of a liver lesion reveals HPV positive cervical cancer. She is MMR stable and her PDL1 is 10%. She is started on palliative chemotherapy with cisplatin, paclitaxel, bevacizumab. She had a partial response that lasted for 1 year prior to progression. What therapy do you offer at that time? Docetaxel, fluoxetine, Keytruda, E.
Exactly. Why are you offering that?
BDL1 is 10%.
Yeah. That's what she would get. Okay. So رح ناخذ آخر سؤال بالcervical cancer.
دكتورة بس سؤال بعد إذنك. هلا ال HPV vaccination how can protect female from cervical cancer?
Vaccination for the HPV.
Yes.
سؤالك عن ال vaccination for HPV, it protects, yes, but that's only if they had received the vaccination prior to starting their sexual activity, because once the patient has the HPV, the vaccine really is not going to clear it. So هلا يعني حاليا ال practice إنه they offer
at 9 years old.
Yeah, preteen, yeah, 9-10. They start to offer them vaccination.
أنا سؤالي إنه قديش ممكن يعمل وقاية من الإصابة بالسرطان، يعني في نسبة؟
Oh gosh, no. I have to look it up. يعني ما عاد أتذكر، بس خاصة هدول يعني as you know, like 16 and 18 are 70 to 80% of cervical cancer are caused by those types. ضلوا يعني يشوفوا إنه في incidence of cervical cancer in those patients, and then the Gardasil came and it was covering more. So yeah, they were reaching almost like 90 something percent. And then the Gardasil 9 has like even more subtypes. So I don't know the exact, probably reaching, above 90%, 95% or something. And I'm just throwing it out there. So yeah, it really had offered great protection for those patients.
Okay, thank you.
طيب آخر سؤال لو سمحتوا.
56-year-old female present with stage 2B cervical cancer. A biopsy revealed that she has cervical adenocarcinoma, not squamous cell cancer. Her tumors tested positive for HPV-16. She is healthy with no comorbid medical conditions. Which therapy do you recommend? Stage 2B.
So that's a locally advanced. Yeah.
Concurrent.
Yeah. Okay, تمام. So رح نوقف هون عند cervical cancer, والnext one will be ovarian. بس إذا ممكن رح أخذ بس 5 minutes break and then we'll restart like 11:08.